That's what I was waiting for. So as more people kind of continue to join right at the time, and I don't think this will be a full long session. I'll try not to ramble. But we do have a previous recent case that we evaluated, and with some kind of, I guess, interesting and kind of unfortunate clinical progression. And the images I'm going to have to show you are all digital microscopy. They're not the actual slides. Eventually, once everything has transitioned to Texas A&M and we are doing current cases, all of those slides are going to be scanned digitally. So we will have scanned slides for review, and then we will have the associated electromicrographs and needle fluorescence. So as we kind of said before, thank you for bearing with us with the transition as we move labs. Dr. Hokamp has been a Hulk when it comes to packing and moving things in bulk. So it's been a couple of weeks, so we appreciate that. Okay, awesome, great. More people are coming through. So Dr. Shropshire, do you want me to kind of show our version of the report, or do you have anything clinical you'd like to start with for this case for Ferdinand?
I guess I can give the blurb on him.
Okay.
Okay, so Ferdinand was a 6.5-year-old male castrated mixed breed dog who kind of acutely started to vomit, had not been eating well, and presented to his RDVM, where they did blood work and they showed that his creatinine was 6. And so they fluid bolused him. And I think they did 2 or 3 fluid boluses and then put him on a fairly high fluid rate. And then noted, they did not have overnight monitoring. And then in the morning noted that he looked like a marshmallow and was significantly fluid overloaded. So he was transferred to CSU urgent care. So on presentation, he was had generalized, pitting edema, was actually breathing okay. Essentially had significant azotemia that ranged anywhere from 5 to 7. His albumin was 2.2, ranged from 1.9 to 2.2. He was also clinically dehydrated. He was hypertensive at 250. He had no fundic changes. And so essentially we worked to try to get the fluid off, and essentially he was doing great. We finally got our UPC back. It was 15, and the plan was to do a renal biopsy. He was in the hospital for about 3 days. Essentially we had started him on clopidogrel and immunosuppressive doses of steroids. He was at a much better state, was no longer overhydrated, was interstitially supported, was eating, drinking, actually was happily trotting in and out of the hospital. And then we took him out for a walk the day that we were going to do the biopsy, and he acutely collapsed and became myotic and non-responsive and was euthanized. And that's what happened.
So I'm since I have 3 screens, are you seeing a golden retriever or are you seeing a copy of the report?
Files with Yachi.
Yeah, we have your OneDrive files.
You got this?
On your Dropbox. There you go.
Okay. Sorry, I had changed to Dropbox. I will have to change it back because I need to find something else. But okay. So yeah. So from a clinical perspective, I guess for a lot of the cases that not a lot, but enough that I remember, for the cases that maybe come from the nephrologist kind of referral centers, it's not uncommon to start to overload these dogs, right? I mean, I kind of would like your guys' clinical aspect of what you deal with on this.
we find particularly the immune complex dogs, whether it's because there's a component of vasculitis as well, become edematous very quickly. Especially if their UOP is changing rapidly and they're oliguric, and even if it's a relative oliguria, they blow up really quickly. So they need very, very close attention to their fluid plan.
Okay. Yeah, because I think that this isn't uncommon where I have this history that, but I guess I would say from a realistic standpoint, are these cases uncommon enough that it is okay for them to start to be managed by a primary care veterinarian first? And then when clinical parameters don't change, that's when they refer, versus should they be referring earlier? I guess is kind of the maybe the frustrating question that it's just a little bit difficult to deal with. So
I think maybe the ones that are presenting as sick, as opposed to the proteinuria is found for another reason, they're presenting for unwellness, and then they're found to be, certainly if they're already asatemic and they're proteinuric, those are the ones that seem to have a pretty rapidly progressive disease and can go south very quickly. We've definitely had dogs that have gone from being pretty normal dogs to very needing dialysis within the space of a couple of days with some of the immune complex dogs. And how long that actual active process in the kidneys has been going on is always harder to prove, but in terms of clinically, they can deteriorate very quickly.
Yeah, but I think I've had one, I think it was Dr. Foster's case, that was an amyloid that was kind of that got overloaded, fluid overloaded pretty fast too. But by the time we got the biopsy, it was kind of, you knew that it was a bad diagnosis anyway. So, okay. So then Dr. Shropshire, did they actually find a PTE or anything like that, an autopsy, or?
No, unfortunately, he died Saturday morning, I believe, because we had people coming in to help us that weekend. But then the necropsy people did not look at him until Sunday evening. So I think just wasn't. So I grabbed his kidney right away, but then he didn't have his full night necropsy for over 24 hours.
Okay. Did they say the comment of thrombi can dissolve? Because I don't believe that.
I think, to be totally honest, I think it wasn't interrogated as much,
Yeah, that makes sense. I could see them not cutting over. Yeah. And
yeah.
Never heard of thrombi dissolving post-mortem. That is very new. That's a new one for me.
I think it's one of those things. Sorry, Dr. Spagnoli is one of our Zoetis anatomic pathologists as well. And I don't know if Letitia's here as well, but I think it would be something where you could always put it in your comment if you really were convinced there should have been a PTE and you just didn't find it, or maybe the vet student messed up the lungs by the time you guys got over there to look at the lungs yourself. And so by then anything that had been there would have been dislodged. But I had remembered even back in residency kind of using that blurb, or being taught to use that blurb. And I don't think it's, I think it's more of a lack of maybe looking in the exact right location, because think about it, it doesn't always have to be pulmonary. It could be brain, right? And
A lot of times when if I encounter stuff like that, I'll say, there is circumstantial evidence that this was there, but it is not found in sections examined. So I don't think, autolysis obscures more subtle signs of thromboembolism, something like that.
Yeah, that's always good.
The fact is, there's very few things that'll make a dog fall over dead, and a dog with hypoalbuminemia that falls over dead, it's almost certain to be embolism somewhere.
Yeah. Yep. Thanks, George. Okay, so you guys are looking at the report, I hope, and let's go through photos really quick before you get to the. Okay, so for some of these cases, for all of these cases in which there is an unexpected, or maybe even maybe not unexpected because the dog was clinically ill, but an autopsy harvest. and maybe the pathologists aren't always available there to do the autopsy stat. So we really appreciate when clinicians can get in, and also we very much appreciate the pathology departments that allow the clinicians to take the kidneys or take biopsy of the kidney as well. So you could get a postmortem true cut sample, or you could remove the entire kidney. You could move both or one, just to send us a sample. So we appreciate that can happen. Hopefully you guys are seeing glomeruli that is an H&E and then a PAS. And the first impression is that there's a lot of nuclei in here. Sorry, my second dog Henley just joined us. So he's coming to work. There's a lot of nuclei within the glomerular tufts. I like to use the PAS for me to see where those nuclei are located. And I know I'm just zooming in on a report because, like I said, the glass slides are currently packed in a pod being ready to move to Texas. But even with just the picture, you can pick up a lot of nuclei. And then the question is always, where are the nuclei located? Are they inside a capillary lumen like this one is? So here we have the capillary space, which is white, and then we have the nucleus here. Hopefully you guys are seeing the error. You're not seeing the pointer.
Oh, wait, it's tiny.
Is it tiny? Okay. Let's see. I don't know. How do you make a pointer bigger? Anybody? Well,
yeah, it's very interesting. It's like it's like a teeny tiny white dot.
I blew the screen, but
the main thing is to not move it very fast so we can find it and then follow it.
Okay. Well, here it's on the green. I'm gonna go up towards the glomerulus.
There.
And so there's a nucleus right under the arrow, and then there are 3 or 4 nuclei to the right of the arrow. And those 3 to 4 nuclei are in mesangial zones, whereas the one underneath the arrow is within the endothelial lumen, is endothelial, so it's within the capillary lumen. But then you can go to some capillary lumens here, which is kind of closer to 9 o'clock, and they have 2 to 3 nuclei kind of blebbing into that capillary lumen. And so you're allowed to have one nucleus per capillary loop. Occasionally it's okay to have 2, just depending on the section. But once you start to get 3 or 4 nuclei within a capillary lumen, that's too many. When you have more than 3 nuclei in a mesangial zone, that's too many. And then all of these other nuclei that I always think a little bit more glassy, maybe glassy is not the right word, but a little bit, they're less dense. Those are all podocyte nuclei. They're on the outside of the capillary loops. And then, so that's one of the impressions, is that they're very hypercellular. And then as we go into the trichrome, you can start to see that there's some red changes along the capillary wall. So if we go up here to maybe like 1 o'clock on this glomerular tuft, we have a couple red dots. There's a couple more red dots at noon. And so all of those little red dit dots are very likely to be immune complexes. I have no qualms when I see it this repeatedly and in multiple glomeruli. If I only had one glomerulus that had this lesion and all the other ones look normal, I wouldn't bet on it. But the fact that there's repeated kind of red nodules along the capillary wall makes me pretty darn certain that there's going to be immune complexes. So had this been a biopsy and maybe the dog was still living, I would have probably sent a text or whatever and said, we need to make sure that this dog is already immunosuppressed. The silver stain wasn't great that day. Usually we like it a little bit darker, but it does kind of highlight the thickness of the capillary walls. And so as we kind of go through more examples, it's that same pattern of hypercellularity, thickened capillary walls, and the hypercellularity being both mesangial and endocapillary. Let's see if I have, here's some more good immune deposits, even on a trichrome. So when we see them on histology, in my mind, they're pretty large that we're going to see them on EM. And then if we look at the other thing I use the trichrome for is I want to look at the interstitium, and I will see if there is fibrosis there. dense blue would be fibrosis. This kind of like hazy blue matrix right here is probably more edema, so it would be more of an acute expansion of the interstitium. I think that this is kind of one of the reasons where it gets difficult to look at a H&E and say whether or not there's fibrosis there, because if you looked at it in some aspects, you would know there's pink there, but then you really want to know how separated those collagen fibrils are. And so that's why you use a trichrome. So that watery hazy thing shows that there's interstitial fluid kind of separating the collagen fibrils there. And so the same pattern exists throughout. So I think I went ahead and messaged Dr. Shropshire and I said, I'm like 99.9% sure it was immune complex disease, but we decided to go ahead and pursue the additional studies because of the case progression. And it's always good to kind of get the full picture of the lesions. So we have an electron micrograph here of a capillary loop. And hopefully everybody can see as I circle around the glomerular basement membrane being this kind of like thin line. And then in the lumen, we have at least two, I guess 3 nuclei, maybe. I can't tell if that one, the one that is at the bottom might be a mesangial nucleus. But at least we have 2 nuclei in that capillary lumen. And then there's just debris and cell fragments, all kind of within that capillary lumen, so that we don't really have any kind of clear luminal space. So I was always trained that when you get capillary lumens like this on EM, and you really can't tell what's what, and you're trying to say, where is the space anyway? How much is this cell fragments? How much of this is nuclear debris? That it's a pretty darn good indication that you've got too many cells there. You have a membranoproliferative pattern or a proliferative pattern. The densities here kind of around, I guess, 3 o'clock are electron dense deposits. And if you're focusing on these guys and you're able to agree that these are electron dense deposits, then you just kind of track your eyes all along that capillary loop and more of them start to pop out. So then actually these up here at 1 and noon are all also electron dense deposits. Is there a clock? We're not supposed to say noon. I think I learned that from working with the Europeans because they weren't sure that that meant. So that means 12 o'clock. So you can start to pick out these smaller densities that are deposits. And then if you follow that capillary wall all the way around to the mesangial region, so now we're at the neck where the mesangium exists, you can see larger deposits. So that's just a higher MAGA, that mesangial zone with more deposits. In my experience, mesangial deposits can be pretty irregularly shaped. They're not always nodules. They're not always discrete deposits. They're kind of irregularly shaped. The same thing with endocapillary, like subendothelial deposits, whereas it's usually more common to have kind of hump-like or kind of well-delineated deposits when they are subepithelial or outside the capillary wall. For example, these. So this is a separate capillary loop, and now we're seeing these electron-dense deposits on the abluminal aspect of the capillary loop. So they're right between the glomerular basement membrane and the podocyte. Because the podocyte is an epithelial cell, we call them subepithelial deposits. And that would be in distinction to the deposits that are on the luminal side of the capillary loop, and that would be subendothelial deposits because they're beneath an endothelial cell. So those are the 2 terms that we'll use a lot, and then we'll track them and see if they go along to the mesangial zones as well. The other location that often is described or delineated would be intramembranous, and that would be deposits that kind of obscure the glomerular basement membrane, the lamina densa. And then we'll have some that we'll say are transmembranous, and that means they're so large, they're basically occupying space from the subendothelial zone, kind of breaking through the glomerular basement membrane and then reaching out to the subepithelial zone. And so those are kinds of all those words that we use to delineate where deposits are located. Figure 4 has some intramembranous down from this. Thank you. Yeah. So they're coming through and they're here on the within the lamina densa. And so the, how do I want to say this? In human nephropathology, location of deposits does have more of an association with etiology and sometimes prognosis. And so we at least use the same terms when we talk about location so that it can match up to what they say. But they have situations like, for example, a case. So if this were glomerulus from a human, and we saw deposits in subendothelial, subepithelial, intramembranous, mesangium, we would have like lupus nephritis at the top of our differential list. And we would say, make sure the patient has been tested for lupus. And with human lupus, it's like 20 different autoantibodies they're looking for. It's not just an ANA. Whereas for dogs, we don't have that same kind of tie between deposit location and disease entity. So we usually talk about pattern. And so we'll say that because there's deposits on a whole bunch of different locations, and the glomeruli are definitely hypercellular, they have way too many nuclei. We put this as a mixed pattern. And mixed is the vaguest term we could come up with that didn't offend anybody in our working group. And then we put the modifier about whether it's hypercellular or not. So we would say mixed membranoproliferative for this. If it was not hypercellular, but there were deposits all over, we would say it was mixed membranous. So, and then I think this is a good picture too. It kind of shows you, so hopefully you can see the arrow is on like kind of a gray bleb. That gray bleb is a red cell. So if you can think about a red cell trying to circulate through this capillary loop that's just chock full of endothelial cells and swollen cells and probably leukocytes, this guy here probably is a leukocyte given his nucleus, he's probably a neutrophil. So we have too many cells in here, whether they're endothelial cells, whether they're circulating leukocytes, and then you see these little squished red cells that are trying to make it through in circulation. And then for the pathology trainees that are also calling in, the other part is looking at the podocytes. So for boards prep, I always taught my residents that you would want to make sure you always have to comment about whether or not the podocyte foot processes are effaced or not. So you at least have to throw that out there. Are they effaced or are they intact? Especially when it comes to a description when you're talking about for boards prep. Okay. Any questions about, here's another, these are two red cells kind of circulating. So remember the glomerulus is just basically a rat's nest of a whole bunch of capillary loops. So you kind of get capillaries right next to each other. So we have some circulating red cells here that are definitely squished as well. More deposits. Okay, so then we do the IF, and this was a pretty big wedge of tissue for IF staining. Sorry, just hit my own desk. Anyway, so here we have a gorgeous glomerulus, and the antibody is labeling the heavy chain IgG. And so our deposits are these little distinct green dots. Every single one of our IF antibodies are labeled with a FITC fluorophore. So it's direct immunofluorescence, which means that we don't have to do a two-step process. We are just having one fluorophore, means that the antibody, the IF antibody, has bound to a heavy chain that exists right there. And so the IgG is always kind of like this, where it's, a couple DIT dots. Sorry, I shouldn't say that. It's always like, in cases where it's immune complex mediated, membranoproliferative GN, we see these DIT dots that are kind of around the capillary loops, also kind of speckled in the mesangial region. So if you remember, the deposits on EM were kind of irregularly shaped. Some of them were quite big, some of them were quite small. And that's why you kind of have this varying intensity of a granular pattern. The C3 looks gorgeous on this one as well. And so now we're showing that complement has been activated in that location, the same location as the heavy chain was located. And so there's the granularity here. These little DIT dots all over here means that the complement's been activated. And then lambda is our most beautiful deposit, or sorry, our most beautiful IF antibody that we use. Every single one of these dots is showing that there's a lambda light chain there. So again, there's an immunoglobulin there. Lambda always stands a little bit stronger because remember, it's probably lighting up IgG heavy chains or IgG antibodies, IgM antibodies, IgA antibodies, because they all have that same lambda light chain. Whereas when you're looking at heavy chains, it's only labeling that particular heavy chain. I see there's a chat question. I'm going to make sure. There's a question about the podocytes. That I usually comment on podocytes, and I guess I should kind of explain to you, Peter, because I don't think we've worked a lot together, but I usually have to issue reports in sequential fashion. So I get light microscopy before I get the electron microscopy. So if I can already see that there's podocyte hypertrophy, maybe they're enlarged, maybe sometimes they actually detach and I can see them floating in Bowman space, I'll put that in my prelim to say, like, I'm pretty sure we got podocyte damage. And then by the time I get to the EM, I'll be able to say, yes, there's foot process effacement. The cytoplasm might be swollen. Oftentimes they'll do things, which I think is also present in this particular case, which is, let's see, they start to make these little tendrils, and the tendrils are it's actually quite good up here at at the top left-hand corner of this image. All of these little tendrils are little microvilli projections. We always make up stories when we're making these diagnoses, and we say that it's because it's not true. Don't anybody quote this, but it helps me believe it. But it's like, oh, they can't have their foot processes anymore, so they start to make these little microvilli. Anyway, they make these little tendrils that are kind of floating out in Bowman space. So I would always put that in my EM portion of my report. But if I suspect it based on histology, I'll also kind of stepwise say there. Because the important point is once you've lost your podocyte, if you lose enough of them, and let's say this dog had made it through, didn't have his thrombotic event or whatever, and then they were immunosuppressing him, it's very possible that the immune complexes could have become more quiescent and not as active. But if we had damaged a lot of podocytes with this immune deposit event, we could have pretty good scarring or pretty bad scarring, I guess, if you were thinking about it physiologically, of the glomeruli. And so there are dogs that will have an immune deposit event or an episode of immune deposition, and then the biopsy can prove that there's immune complex disease. And then later, after lots of doses of mycophenolate or whichever drug of choice the veterinarian puts them on, they will have segmental sclerosis. And so their UPC usually goes down, but it's not usually normal. So, and now we're in a scar phase. And so then the dog is kind of maintained in the segmental sclerosis pattern. And so then you're kind of like, well, his UPC is probably never going to get normal. And we are fortunate enough to have repeat samples from some of these dogs. So sometimes they're either rebiopsied or maybe eventually just end of life decided to euthanize for a different reason. We can see that there's now segmental scarring, and that's why the dog's UPC was settling around 2. And so we do have repeat biopsies on some of these. So it's good to comment on whether the podocytes are healthy or whether they're abnormal and detached. So good question. Any other questions about this particular IF or EM? Yes, Dr. Baden. Oh, I don't think she meant to unmute herself. Yes. Nobody has pictures today, so I'm only looking at whether or not you've muted yourself or not. So, so this is an example of a mixed pattern of immune mediated membranoproliferative glomerulonephritis. I'm uncertain whether or not you were ever able to find what etiology could have started the immune complex deposition, Dr. Shropshire.
Yeah, I was just gonna, the only thing I was curious about is, I guess, I mean, I haven't been able to submit loads of these. We actually, again, paid for this. But one day I'll find a owner that can afford it. But I think they're so helpful. So we're going to try to figure out some sort of price structure or something at CSU so we can get more. But no, we did obviously lepto because it's kind of the time of year we see that around here and initially. And The dog was on no medications, no weird supplements. The dog was actually from California and they were here on holiday. So that sucked really bad. But weirdly, the only thing that I think was just incidental, but it was obviously complicated things substantially, was the dog had this reported concentric intestinal mass that they were commenting they weren't sure what it was. And so we were going to serial ultrasound the dog because we were concerned that was going to rupture with the high dose steroids. And on necropsy, it was a perforated intestine that had not become septic. It had just partially. So I think he died beforehand and there was no evidence of peritonitis. Histologically or grossly, it looked like maybe a previous foreign body. It wasn't actually neoplasia, but really didn't find anything at all. So I was just curious with how much deposition there was. And he'd actually had a chemistry done 3 weeks prior and just for wellness. And his creatinine was 1.1, I believe. And albumin was normal. And so it seemingly was quite acute, but again, I never found the trigger, but I just was interested at, it was, the deposits were everywhere. And so I was doing the same thing, reading in People about lupus, and I just was curious if anyone had any thoughts for if I should have been looking for something different or other things or another immune thing that we don't quite understand.
And tick-borne was completely negative?
Yeah, PCR, serology, no evidence of vasculitis systemically elsewhere, never febrile. Yeah.
So, I mean, I would say on the people that are I'm looking as that are attendants, like Friendship sends a lot of these, NC State sends a lot of these kind of immune complex lesions. For your particular case, the deposits were everywhere, but if the EM actually did not show that much remodeling, and that might have been why the silver stain, although my original thought process was it was just kind of a weak silver stain, but it might be just that the dog didn't have enough time to remodel the glomerular basement membrane. And so I would say that the acuity would be, is definitely believable. But again, I can't say 5 days versus 2 weeks. I don't know that. But oftentimes if they've been smoldering for months, we'll see a lot more glomerular basement membrane remodeling. And it's always a little difficult because that stain, the Jones, the silver stain's a little bit hard to perfect every time. And so sometimes you're like, well, maybe it's just a weak stain day. But now being able to compare it as I just did with the EM, it probably actually didn't have a lot of time to remodel. So I think it is an acute, within the past couple of weeks. But I don't know other than that as far as, and the cause for the concentric mass, was there a tumor underneath that partially perforated or?
No, there were basically what looked like little pieces of grass and maybe sticks. So I think it was like a incidental penetrating foreign body potentially, but I didn't think it was related necessarily because it hadn't yet perforated, but it didn't help me at all.
Yeah.
Early on, before I was labeled a kidney person, one of my prominent interests was immune-mediated disease in general. One of my early mentors was Niels Pedersen back when he wrote about polyarthritis and other stuff and whatnot. And so I've always been looking for lupus cases, and I've long thought that it was they were not at all common in dogs anywhere near as much as they were in people, but they do happen. In one case that I managed personally at Texas A&M was sort of a middle age. I have to look him up, but he maybe 3-4 year old golden retriever with immune complex glomerulonephritis that Brian Berridge and I documented very thoroughly. And his ANA was his ANA titer was in triple digits, 2,000 something or whatnot. And we worked really hard on him, and what he died of was a thromboembolism. So I keep looking for, but I rarely find them. But I wouldn't rule it out as a possibility in, for an abrupt onset of an overwhelming immune complex GN like this.
Yeah, and I think there's the autoantigens, or the autoantibodies, I should say. That's the correct word for this. I don't think we have sensitive tests to know what else it would be accidentally binding to. Dr. Jeanette spoke at one point in time and kind of gave this story, which I don't know is necessarily true, but it is interesting to think about the avidity of the binding between the antigen and the antibody. So whether it's an autoantibody and native antigen, or maybe an exogenous antigen or whatever. So you have these kind of hanging out and maybe in circulation. And then why in the world do they end up in certain locations as immune complexes in the kidney? And so his comment, I think at one of our meetings, was that if they are kind of bouncing off of each other and occasionally sticking together, but they're not, it's not a very strong bond between the antigen and the antibody, then they might have the easier ability to kind of penetrate portions of the glomerular basement membrane because they have detached from one another. And then they get kind of wedged up into the space between the podocyte and the GBM, and then they reattach. And then there's a whole bunch of them that kind of conglomerate in order to make that more discrete immune deposit. And that might be why we can see deposits that are in that subepithelial zone. And maybe those antibodies and antigens just don't have as tight of a bond. Whereas the deposits that seem to be more subendothelial per se, or for example, would be more tightly bounded. So they couldn't really ever disassociate from one another and start to cross the GBM. And so that might be why sometimes these complexes that are created are established deposits in different locations. And I don't think anybody's ever experimentally proven that, but I think it's an easy story to tell ourselves about, like, well, that's why sometimes deposits are in one location, other times they're in a different location. And then we have your dog where they're all over the place. So in my thought process is, like, when they're all over the place, there must be a wide variety of how closely bound they were to one another. Maybe there are a whole bunch of multiple autoantibodies and multiple antigens. And so it fits more with what we think about when we think about lupus. Doesn't necessarily mean it's lupus. It just means that it's multiple antigens and multiple different antibodies identifying them. So what would you have done had you gotten the diagnosis? You would have immediately started on immunosuppression?
To be totally honest, I started him on it for like 20 minutes when he came in through urgent care.
It's perfect. We do get a lot of those where we already, by the time I send them an email, I'm like, you need to immunosuppress this patient. They're already like, it's already done. Like we took the biopsy and then we started the immunosuppression. And sometimes you actually start the immunosuppression before you take the biopsy. So any other comments or suggestions from anybody else regarding this case?
Just one quick comment, Rachel, on the story you told from Dr. Jeanette. Even an antibody that's not associated with an antigen is still too big to pass through a normal GBM. And so why would it cross in the first place? Well,
that's a good question. I think that that obviously we're not talking about IgM or anything like that. We're talking about like the IgG antibodies and stuff like that. I think that there is some question that maybe the GBM never really was completely as impermeable as we thought it was. And I think it was at STP when he was giving his large lecture as the keynote at STP, Mary, that he kind of mentioned that story about how when you see glomerular damage, like this might be why you see it subendothelial versus subepithelial. Oh yeah, sorry. GBM is glomerular basement membrane. I apologize, not glioblastoma multiforme. So I don't think it's ever been proven experimentally, but I think it's one of those things that can kind of help in a teaching aspect of like, there's a reason that some of them get through and some of them don't. And I think that when you have, I do think that when you have deposits all over the place, that you probably are dealing with more than just one single antigen and one single antibody clone, I guess. That's the only reason I brought it up.
Thanks.
Okay. Anybody want to do a GWiz case? Okay, well, you're gonna do a GWiz. If there's any other questions, let me know, or put them in the chat. This is, I know I haven't shown it yet because I have to figure out which one I want. But I'm going to be showing you a sample that actually came through Zoetis. And it was a 4-year-old female spayed mixed breed dog. And the history that I received was that the dog had acute onset blindness. They detected retinal detachment. And then following that, I think it was being managed by the clinician, maybe I think even ophthalmology, and then developed pretty severe abrupt onset of large bowel diarrhea. And so they put the dog on steroids, nothing seemed to work. And then the dog progressed to have vestibular signs, spinal ataxia. They did a whole bunch of infectious disease testing, and they treated with, they did a whole bunch of infectious disease testing, was negative for 4DX, Neospora, Blasto, Toxo, Histo, Cryptococcus. But they went ahead and treated with a whole bunch of other drugs. So the dog got clindamycin, fluconazole, metronidazole, Tylazine, hydrofloxacin, and sulfasalazine, but still had really bad hematochezia and large amounts of GI, large intestinal diarrhea. They did a colonoscopy. The dog had ulcerative colitis, so they biopsied the colon. They recovered that night. The dog was doing okay, and then it died overnight. So they did an autopsy, and they found white foci all over the place. And I actually think they're the ones that told me what they thought it was, and they were correct. So GWiz for everybody, which means I actually have to pull it up. And I think this is the better of the slides. Let's see. I know you aren't saying anything, I promise. I'm going to bring it so that you can see it. Okay, hopefully, are you seeing a digital slide? Yes?
Yes.
Okay.
Yeah.
Okay, so yeah, it's a little bit slower. So this is a whole slice of kidney. I have a whole bunch of these slices of kidney. And there are streaks kind of radiating from the corticomedullary region out to the cortex that are going to be filled with inflammatory cells. And the tubular profiles in these regions are going to be undergoing degeneration, necrosis, and some degrees of atrophy. And then if you can look elsewhere away from that streak, the intervening portions of the renal cortex are fairly normal. And so as we go with higher MAG, hopefully everyone who is an anatomic pathologist, a clinical pathologist, and an internist can clearly see that many of these inflammatory cells are beautiful plasma cells with great perinuclear halo and round nuclei. They have a pretty good amount of cytoplasm. There's some admixed mature lymphocytes as well as some macrophages. But then, so that's all fine for inflammation, typical inflammation. But then we start to look into the other regions, and we have these kind of weirdly shaped, slightly basophilic, sometimes crinkled looking structures that are hanging out in the interstitium. Sometimes they're within renal tubules as well. Sometimes you can kind of see that maybe they're even within a macrophage or right next to a macrophage that is, responding to these little organisms here. So I was pretty certain the infectious agent, and we did do a hunt, although I think this one might be a good one. You start to see that the shape itself over here at like kind of 9 p.m. I'm not sure what the deal with my small arrow versus large arrow it might be in the situation, but they're round organisms, and they kind of have a tripartite division. And so I was pretty certain that we had good examples of this. We have a couple of good pictures here that I took. Actually, I don't think I took these. I think Catherine took this for me. Everybody got really excited when we saw this. So we all went hunting around for more organisms to try to find the best little examples of this. So I want everybody, and I haven't said the name of it yet because I'm curious. I want everybody to write in the chat what you think it might be. If I can find the chat, that also could help. Chat, anybody? Chat, we have. Awesome. Anybody else? Yay. So we already have 2 people that have told the diagnosis. This is gorgeous for prototheca. And protothecosis is a fun word to say. The clinical pathologist, I think you probably, I would say for you guys actually that live in the South, how often do you get to make this diagnosis? Like maybe like once a year, occasionally? Okay, did you get to make it in Ohio too, Jessica?
I think I saw it once or twice. That sort of tripartite division is real classic, but I think I've seen it once or twice up here.
So question about the green. No, I did not. They did not say anything about the green tinge or if there was a green tinge on the autopsy. I think they just saw the multifocal inflammation. It was throughout everywhere. It's in the heart. It's gorgeous in the heart. I think the picture I showed you last was actually in the retroperitoneal fat. And so I think it was pretty much in every single organ that they submitted. But I can share really quickly. I think Dr. Baden, you have a paper, or at least NC State has a paper about this in dogs, because that's what I used for my seminar. Oh, yep, there you are, Dr. There you are, Dr. Baden. So they looked at dogs that had systemic protothecosis and were able to document acute kidney injury. Sometimes you can pick it up in the urine. So I think it does kind of warrant that if you have a patient that you know other organs might be affected or might have prototheca, or based on location, it might be helpful to try to look at urine. And I think the picture I took for when I gave this in slide seminar, this was from that paper, I think, in the urine sediment. And then if we did special stains, doing a GMS or a PAS, and I'm not actually sure if I did those extra special stains on this case. Anyway, so kind of a GWIZ example of a lesion that was pretty prominent throughout the renal parenchyma. And it also explains the blindness and also the GI lesions as well. So, but I think I've only seen it in this particular case in the kidney. I have diagnosed other fungal organisms, which I have been surprised have made it to the kidney, but this was the first time I think I've seen prototheca.
Rachel, sorry, where did you say this dog was from, or do you know?
Let me look at history. Yeah, it does not. I'd have to look it up. I'd have to see where the practice is.
No worries, no worries.
Yeah. Yeah, so I do think I thought was kind of cool, and hopefully now you're still seeing a large section of the kidney. That radiating streaking pattern, I think is pretty interesting for this, because when I was looking at it, obviously it was an autopsy case, but the first slide I obviously opened was the kidney, because I wasn't going to deal with the other organs until I knew what was going on with kidney. I was like, oh wow, this stripy pattern is very strange. And I often think about stripy patterns when I think of a vascular distribution, and I was quite surprised to find that there was something kind of infectious kind of in all of these little stripes. So I don't know if they got their GI biopsies. I got GI on autopsy.
Hey, Rachel, you think the stripy pattern could be
hematologic spread? Yeah.
Yes.
That was my thought, but I just thought it was kind of, because normally when I see this, I'm like, oh, something's going on. It must be a vascular thing. Normally, it would make me worried more of like an infarct or maybe like radiating fibrosis, but it was just very apparent at that very low mag view. And then I was like, saw these organisms. And then I went to all the other organs and I was like, oh, I was very impressed with how disseminated it was. But they had done a lot of drugs for this dog, and they also put the dog on steroids at one point. So, okay. Any other kind of questions about this GWAS case? Okay, well, hopefully everybody was able to access TAMU's Zoom easily. If you have other people you would like to invite, and I think Letitia, I mentioned you might not have been, I think I saw your face, but I don't know if I heard you. I do need to add your classmate to the distribution list. I just, with the transition, I forgot to do it this time, but you guys will get another invite for September. No, this is September, for October. And we'll be able to have another session. I strongly encourage all of you trainees or budding nephrologists to volunteer to participate with a case, because if it's just going to be me the whole time, I'm probably not going to be able to deal with this. I don't know how long I would be able to put on a whole set of rounds every single month just by myself. So having the clinical information there has been very helpful. So if you guys ever want to do present a case, just let me know. Like for this particular one, I sent Shrop the final and she's like, this would be fun to discuss, not fun, but this would be a good one to discuss in rounds. And so I just flagged it as being a good potential rounds case, and then reached out to her prior to the starting of this round. So we can do this as much as we can. Okay. Okay. Thanks, guys. See you next month. Bye.
Thank you.
Welcome.
Bye.
Thank you.